About dinner time, so let's quickly look into yeah. So all inside meniscus repair system. This is something which has revolutionized the meniscus repairs, and there have been various generations of these meniscus repair devices which have come in, and right now in the market, I feel the best is fiber stitch, which is very handy. The one of the advantages is that it is a all suture implant. Being a soft implant, it has less stresses on the capsule and the meniscus where it holds on. There's a good depth stop ranging from 10 mm to 18 mm. So with every 2 mm of increment, one can easily visualize and then have a depth stop there. Ergonomic hand piece. This is one of the best hand pieces you have. Some of the devices you cannot make out which is up and which is down. So this has got a good grip, and it's got that wheel through which you can roll and control your hand movements. It's a double mattress reliable fixation. So you see here the first mattress sits there, and then the second mattress goes on and secure the first mattress. So even if you have the first mattress stitch which is a little slack, you can have a second mattress sitting in well and good. Of course, no knots in the articular surface. That's of course a good kind of an advantage on the contrary to some other repair devices. Complex case, let's just look into a couple of cases here where which I came across last week, which I thought is worthwhile discussing in this forum, and probably showing the advantages of these devices. The latest edition of your fiber stitch comes with a 23-degree curved needle, and that's exactly the plus point of these devices, and very handy in such cases. This is a complex tear, a horizontal cleavage kind of a tear with the kind of a oblique, almost a radial kind of a tear pattern. I've opened up the pocket, cleaned up, and usually I enhance my biology here. I just take the blood, probably semi-clotted blood with the spinal needle. I push in a few clots and blood in between like a sandwich here before I start my repair. This is a usual routine what I do. Now you see this, it's this concave or a convex structure of your femoral condyle is what prevents you from getting those kind of your devices there. Your 23-degree curved needle makes your penetration easier. It doesn't scuff any cartilage. It goes smoothly, and I usually take a crisscross kind of a repair here. In this, what I've done, since it's a radial tear come horizontal cleavage tear, my first bite takes the upper and the lower leaf, and then another bite down here. So it's in stitch from here to here. It holds your radial tear as well as it closes that leaf. Now second stitch in a opposite manner there. I have taken one on the lower part and then the other part. So here you see your radial tear is well closed. Now I feel sometimes this is enough. In case if you feel that this is inadequate, what one would do, you would look at the flaps there. There are still few dangling flaps. So what you would do, you would try to close it. How do you close this? I would take another fiber stitch, put a bite down into the inferior capsule. Now that holds the lower flap, and then put one. This is like a vertical mattress suture what you're pushing in here. My first knot is tightened off. Now before I tighten my second loop, what I do, I would take in a little bit of the synovial tissue. This has got good osteoprogenitor cells. I would place it in between that loop. Placing it is a little challenge. Stop your water flow in here, and then the second loop is gently tightened to hold this synovial tissue here. See, these kind of tears are extremely unstable tear, and usually it were considered to be irreparable some time back. So you need to do whatever biology you can enhance for these kind of tear. You see here, it's kind of a crisscross repair what I've done. Good stitch there, holding both the sides of your meniscus, and then again I go ahead and enhance the biology with some blood clots. This is how it would look at the end of it. A second case here, this came in as a surprise. MRI doesn't reveal the extent of a tear. Of course, there was an osteochondral lesion there. the posterior horn of the lateral meniscus seem to be torn, and then there's a complex tear of your medial meniscus root, and of course a complete ACL tear. On diagnostic arthroscopy, we did have a complex tear of the medial meniscus. I will go to the lateral meniscus later. There was osteochondral lesion here. Of course, ACL reconstruction also has to be done. So you can have various repair devices, but all those would be time consuming, since you need to do all of your repair work in a single sitting, and you would choose the fastest and the quickest way while securing the meniscus well. So here a horizontal cleavage kind of a tear, and of course a complete transection from the root. This is probably what we saw in the morning, kind of this tear. I have a transection here, that's the root, a radial tear near the root, plus a horizontal cleavage kind of a tear here. Again, I will start my repair from posteriorly to anteriorly. First I will do my radial tear repair. In a similar fashion, I would take this, I would pause it here. Now, as a rule, you know that you're not supposed to put your medial root device from your medial side to the lateral side, but the advantage of this 23-degree curved is that you can penetrate and then turn your angle so that it doesn't go into the lateral side, so that you escape your arteries and nerves there. Once you have done that, I would take another stitch. I would take, in a similar fashion, I would take both the leaves. This gives that advantage. You see that curved, it allows me to take a bite through the superior and the inferior leaf, so that I hit two targets in the same in a single bullet. So here you have, this is as I said, it's a double looped suture, which gives you a good tension. Now next, what I would do, I would take my stitch from inferior to superior. I've placed my cannula down. Now I would take the reverse curve this angle and take a bite from inferior to superior so that I hold both the leaves from posterior to inferior to superior, and then again I would take another bite in the root. Hence my radial repair is done. It is well secured. This is the best what I could have done there. Next, I would pay my attention towards my horizontal cleavage type tear. I would rasp this and enhance it to create some amount of bleeding and to stimulate the biology. I would then take the advantage here again, even if I am doing my body repair, I can use the same portal, so I do not no need to put multiple portals, since my curve 23-degree curve device gives me an access to all the nook and corner of my posterior horn and body. Yet again, I would go ahead, put in some cloths in a similar sandwich manner, and following that I would go ahead and repair my horizontal tear. You see here the advantage of this curved. I'm pretty much fascinated by this device, because this gives me so much of a lever. I can put in my suture anchor, I can put in my repair stitches anywhere, and a good pilot hole here with a good thick kind of a device holding into the capsule, especially in these flimsy tissues, makes this device very, very handy and useful. Here I stitch back my my horizontal tears. Once I've done that, this is the repair what I would see at this stage. I would then go ahead and cater my osteochondral lesion. I've done a Oates there, good nice 10 mm plug put in there. All this would get done in about 15-20 minutes, so you still have time for your ACL reconstruction. Once I've done that, I go into my lateral compartment, and for my surprise, the lateral compartment looked something like this. A grade 4 condyle lesion in a tibial condyle. That's more of a degenerative lesion, and a complete transection of my lateral meniscus. There's a tissue loss from the root up to the posterior third of my lateral meniscus. Ideally, there are various techniques which have been described to fix this. Dr. Sheetal has shown using a semitendinosus tissue here and reconstructing that posterior part of the lateral meniscus. There is a grade 3 OA changes in the lateral tibial plateau. So I am not going to venture into all those things. What I did, again, I take this a curved fiber stitch device and anchor the free end of my posterior horn of my lateral meniscus into the popliteus. This would prevent excess excursion of my lateral meniscus and probably save whatever lateral meniscus is probably worthwhile saving. I use the popliteus as a post here, so it's quite handy at times when you do not know what to do. At the end of it, you have this kind of a repair in the lateral meniscus. Sometimes you come across certain tears which you think is not repairable. Look at this. This has got all kinds of tears in that. You have a radial tear, you have a flap tear, you have a bucket handle tear, and you have a root tear. This is your bucket handle tear. Then you have your oblique tear. Then you have your flap tear, and of course a root tear to be the cherry on top. Do we really need to repair this meniscus? Yes, of course. If it's a younger patient, do all what is possible. At the end of it, you would get a good repair, and probably whatever worthwhile tissues can be saved, do save it. Thank you.